Hi, I'm Michelle McCarthy. I'm an SHO in Cork University Maternity Hospital, and this video on the diagnosis and management of PPROM is aimed at undergraduate medical students.
PPROM stands for preterm pre-labour rupture of membranes. When we're talking about preterm here, we mean at a gestation between viability and 37 weeks. Early PPROM occurs before 24 weeks and has a 95% fetal and neonatal mortality rate, according to a recent CUMH study. We are not concerned with those instances here. PPROM complicates 2% of pregnancies, but is responsible for 40% of preterm deliveries, both iatrogenic and spontaneous. 50% of women will labour within 24 hours of rupture. Risks resulting from PPROM include chorioamnionitis, which is an intraamniotic infection affecting between 4 and 15% of cases. This has implications for both the mother and the fetus. Prematurity, sepsis, and pulmonary hyperplasia are all associated with an increased risk of neonatal death. If there is resulting osteohydramnios, this can lead to cord compression, particularly in breech presentations. It can lead to facial anomalies, and placental abruption can also occur. The diagnosis of PPROM is clinical, with the history telling usually of a gush of fluid vaginally followed by a more or less continuous dribble. A sterile speculum should confirm, and we should avoid a vaginal exam unless the woman is in labour. An ultrasound scan can confirm oligohydramnios.
A full obstetric history needs to be taken. The timing of onset is important. The typical history is a gush of fluid followed by a continuous trickle. You should ask about signs of early preterm labour, especially atypical signs such as unusual back pain or pelvic pain. Pay heed to differentials in your questioning, such as UTIs, incontinence or thrush. Examination for abdominal tenderness or signs of infection is important. Inspect any fluid that's collecting on pads.
When performing a sterile speculum, good positioning of the patient is essential. You can place a pillow beneath the pelvis to raise it up off the bed. Be mindful of her privacy and dignity. Offer a chaperone if you're female, and you should always have a chaperone if you're male. Good lighting is important. The patient should ideally be resting supine for 20 to 30 minutes prior to speculum examination. A pool of amniotic fluid seen in the posterior vagina is diagnostic. Fluid may be seen trickling through the external os, and dilatation can be assessed. You should take this opportunity to take a high vaginal swab. This can subsequently guide antibiotic therapy if necessary. You should also note if there is any blood or foul odour. There are other tests of which you should be aware. These include the nitrazine stick, the amnisure test, and examining the fluid for the ferning pattern. These are not used routinely, however.
The nitrazine stick detects pH change in the amniotic fluid. The yellow tip will turn black if it's present. It's 90% sensitive, however false positives are as high as 17%, and this is usually due to contamination by either blood, semen or urine. The amnisure test is a rapid immunoassay. It's close to 99% sensitive and close to 100% specific. There's 3 steps to performing it. You place the swab in the vagina for a minute, you then place it in solution for a minute, and then it takes 5 minutes for it to be read. The single red line here shows negative. The third option you have then is to microscopically examine the vaginal fluid for the characteristic ferning pattern due to the crystalline nature of amniotic fluid. However, none of these replace a clinical diagnosis.
Once you have diagnosed a PPROM, you should admit the lady to hospital. This is in case she goes into spontaneous labour, but also to monitor for signs of fetal distress or chorioamnionitis. We will deal more with this in the next section. As stated previously, you should take a high vaginal swab, you should take a low vaginal swab, and midstream urine. These can guide antibiotic therapy. You should also take the preliminary bloods, especially an FBC. A transabdominal scan should be performed to assess fetal weight and also the presentation. As mentioned previously, cord compression is more likely in breech. You should start prophylactic antibiotics and administer steroids for fetal lung maturation. There is some controversy over the administration of tokyolytics. Usually, they should be avoided.
The administration of prophylactic antibiotics in PPROM has a number of benefits. Most notably, it extends the time to delivery. It also reduces the rate of chorioamnionitis and neonatal sepsis. It does not, however, improve neonatal mortality. An example of a regime that's often used is 10 days of erythromycin, 250 milligrams 6 hourly. We should avoid coamoxiclav as it increases the incidence of neonatal necrotizing enterocolitis or NEC. Steroids should be given to the mother if she's after gestation between 24 and 34 weeks. Randomized control trials have shown that they reduce the risk of RDS, intraventricular hemorrhage, and necrotizing enterocolitis in the neonate. An example of a regime that's often used is 2 doses of 12 milligrams betamethasone 24 hours apart. Tocolytic agents such as nifedipine, which delay the onset of labour, are not recommended in PPROM. The reasoning for this is that subclinical infection is common and you could end up maintaining the fetus in a toxic environment. However, controversially, there may be some role for them in a situation where you need to delay labour long enough to transfer the fetus in utero to a tertiary centre where a neonatal ICU is available.
Assessment for chorioamnionitis is primarily clinical. 4 to 6 hourly OBS should be performed and maternal pyrexia or tachycardia noted. Correct recording on the IMUS chart is important. Abdominal tenderness or foul-smelling discharge should be observed. Fetal tachycardia is a late sign of infection and can be detected by handheld Doppler or CTG. White cell counts and CRPs should be monitored, although they are not satisfactorily sensitive or specific and are associated with high false positives. Ultrasound scan to assess biophysical profile and Dopplers can be used to help assess fetal well-being. However, there is no evidence to show their usefulness. There is conflicting evidence and opinion on the optimum time for delivery. Delivery should always be undertaken if there are signs of infection or fetal distress. In the absence of these, however, delivery may be considered from 34 weeks, and the pregnancy should not be allowed to continue past 36 and 6. So, in summary, preterm premature rupture of membranes is rupture prior to 37 weeks gestation, complicates 2% of pregnancies, and is associated with risks such as chorioamnionitis, prematurity, sepsis, pulmonary hyperplasia, and risks associated with oligohydramnios. Diagnosis is clinical based on history and sterile speculum exam. The patient should be admitted for monitoring investigations, antibiotics and steroids. 4 to 6 early observations should be undertaken. Delivery should be for any signs of infection or performed between 34 and 37 weeks. Thank you for listening. More information can be found under the RCOG or RCPI guidelines or in the relevant chapter of 10 Teachers.